Hello again, this is Christine, and we're going to talk about inflammation. And it's a very closely related topic to immunity, so you'll see some overlap. Inflammation is the immunologic defense against tissue injury, infection, or allergy. And we were going to go over these terms in collaboration and collaborate on them, but now we're just going to learn them. We have acute, chronic, exudate, extravasation, and hyperemia. I'm going to go over acute and chronic, and I'm going to have you look up exudate, extravasation, and hyperemia. Okay. The inflammatory process has 4 potential outcomes. The first is divided into 2 parts. First of all, there's a period of active inflammation, which is the initial response to tissue damage, and this is just a non-specific response and focuses on getting rid of the dead tissue, promoting an immune response, and protecting against infection. Excuse me. After a period of time, the damaged tissue is then replaced by identical functioning tissue, and the old tissue or the pathogen is removed. This is the best scenario in the inflammatory process, and it's associated with a high incidence of recovery. I'm sorry, I don't know what this last sentence here is not right. This is the 4th outcome. I don't know why it's still there. I apologize. But this section here is what you want to have happen. You want the body to mount an inflammatory response. You want the body to get rid of the pathogen. And you want the body to replace the damaged tissue with fresh tissue. A second possible outcome, which is not as good as the first, but better than the others, is a repair of the damaged tissue and the formation of scar tissue. And this occurs when the cells are not able to restore the tissue to its previous state of well-being. This happens a lot in burns. When there's a substantial tissue damage. The third possible outcome is the development of chronic inflammation. This usually occurs after a viral or bacterial infection, and it occurs frequently in those cases. And what happens, the pathologic agent remains active even though the pathogen has been taken care of. The body still remains activated and doesn't get switched off. This outcome is associated with the increased incidence of morbidity and mortality. This is not what you want. The 4th possible outcome is initial death of the tissue and ultimately death of the host. So what you want is on behind door number 1. There are different types of injuries that can cause inflammation. A mechanical injury, such as a torn rotator cuff. A thermal and electrical injury would mostly be burns. Chemical injury could be something a little more obvious, like acid burn. But also even some of the medications that we give as nurses can cause a chemical injury if they leak into the soft tissue instead of staying in the vein, which is really important to make sure you're checking your IV site. And also if you're giving a medication that has that potential side effect, you want to closely follow the infusion protocol and make sure that you mix. If it's an IV push medication, make sure you mix it with some saline or some sterile water to dilute it. Radiation injury causes inflammation, such as when you are being treated with radiation for cancer, and any biologic assault by a virus or a bacteria. We have 3 categories of inflammation: acute, chronic, and repair restorative. Acute inflammation is the immediate response to tissue injury, and that can be anywhere from a few minutes to a few days. And that's characterized by 5 cardinal signs, and these have been recognized since the time of Plato and Socrates: redness, swelling, heat, pain, and loss of function. You need to know those. And they're also associated with 3 physiologic changes: increased blood flow to the area that was damaged, increased vascular permeability to allow the exchange of white blood cells and platelets and red blood cells in that area, and the removal of items that aren't supposed to be there, and then the migration of leukocytes from the blood to the tissues. So you have the increased blood flow, the increased vascular permeability, and the migration of the leukocytes from the blood to the tissues. In chronic inflammation, that can occur for weeks to years after initial injury occurs, and the response by the body is out of proportion to the stimulus. So it would be as if, I think we've already given this example, but it's as if a boy throws a rock at a convoy, and then the convoy decides to retaliate by dropping a nuclear weapon. Your body is responding out of proportion to the threat, and it just doesn't switch off. There are many types of systemic inflammatory diseases. Some inflammatory bowel diseases are ulcerative colitis and Crohn's. And I did hear a program on NPR about why they think why there is such a increase now in inflammatory bowel diseases, and why it's so much more prevalent in Western countries. What they think is that for most of humanity's existence, we have eaten food and existed in an unclean environment, and what the food we eat typically had a lot of pathogens on it. So our body had to respond by being very vigilant. Now that, especially in the West, that we're eating, sterilized food, everything has been cleaned and washed off, our body is programmed still to be hypervigilant, and it doesn't need to be. So it sometimes reacts to the food we eat, or instead of to a pathogen that normally would have been there, in any other stage of humanity's existence. It's very interesting. They actually have had some people who are so desperate to fix their ulcerative colitis and Crohn's that they decided to deliberately infect themselves with a kind of benign tapeworm to see if their symptoms would resolve, and they did. So that's just one theory behind ulcerative colitis and Crohn's. And function of the inflammatory response, again, the function is to restore the area to normal functioning, and if that's not possible, to repair it or stitch it up when the restitution of functioning cells is impossible. We already went over immune system. I'm not going to go over it again. And a little more in depth here with the steps in the acute inflammatory response. You have the tissue injury. When the tissue is injured, there's a release of chemical mediators like cytokines. It causes vasodilation, or to dilate means to increase in diameter. So the blood vessels and the lymph, they're increase in diameter, and that allows an increase in blood flow. You get swelling and retraction of the activated endothelial cells in the skin. And then It allows increased vascular permeability or increased movement back and forth, and leakage of small plasma proteins. And then what happens is there's a walling off of the area that has been damaged. The immune response to that area that's been walled off increases. There's the formation of exudate, which is like the purulent discharge that we all know and love. And then there's a movement of glucose and oxygen to the site to be repaired. And finally, the release of chemical repair factors from activated endothelial cells. So in summary, what you need to come away with is that the body recognizes that there's been an injury. It increases blood flow to the area so that an exchange of white blood cells, platelets, etc. can take place, and the removal of the old tissue can occur. And it walls off that area to protect the rest of the body from the infection. But at the same time allowing glucose and oxygen to the site for repair. This is just a little more in depth. So the organisms invade the healthy tissue and infect the cells. The organisms cause damage to the tissue that results in a release of chemical substances that attract the local immune cells to the site of inflammation. Step 2 is the activation of the local histiocytes in the tissues. The first cells of the immune system to respond to the infections are tissue histiocytes or macrophages. They start to fight back the invading organisms until tactical support comes from the white blood cells in the bloodstream. Step 3 in the acute inflammatory process occurs when biochemical messages are sent and the body responds to them. When the fight from the local immune cells and the invading organisms reach its height, they release secret chemical substances that leads to the widening of the local blood vessels to bring more blood to the site. The increased blood flow to the site leads to the characteristic signs of swelling, redness, warmness, and pain. In this picture, we see the mouth of a patient with a sore throat. That's a pretty sore throat. In step 4, the dendritic cells, better espionage and better response. These cells bring information and samples from the invading organisms. They process them and send the information in the form of chemical signals to the upcoming immune support from the blood. This is very important because if these cells detected that the invading organism is a virus, they would send a cell to the CD8 T lymphocytes to come to fight. If they detected that the invading organism was a bacteria, they would send signals to the neutrophils to come fight. Another function of these cells is to instruct certain types of cells called memory cells, which was responsible for the long-lasting immunity after the attacks. Okay. Sorry. In step 5, there's the removal of the main fighting force. The rescue cells come from the tissue under attack, reach the white blood cells. They arrive in forces to give tactical support against the invading organisms. And the kind of tactical support you get depends on what the antigen is that's infecting you. If it's neutrophils, and you can bet that you're under a bacterial attack. If you have a viral attack, the body will send a CD8 lymphocyte. These cells start to give tactical support and eliminate the organisms, and then phagocytosis occurs, either eating up the enemy or there's a cell-mediated cytotoxicity of injecting the lethal chemicals into the invading enemy. So the lymphocytes inject chemicals, whereas the neutrophils go ahead and chomp them up. After the invading organism has been eliminated, the white blood cells start to get out of the site of the infection, return to the bloodstream. Dead cells are taken away by phagocytosis. And this is where the inflammatory process really differs from the immunity process. The fibroblasts start to repair the damage at the site of inflammation, and after a period of time, the site returns to normal, like it was before in the inflammation. This is a quick video. That looks like a T4 cell. Or maybe a neutrophil. What are the consequences of excessive or ineffective inflammatory response? You can have local tissue damage from compression or swelling in the area. You can have the development of chronic inflammation, and that can lead to diseases as diverse as arterial sclerosis, chronic renal disease, and even neurologic disorders like Alzheimer's and multiple sclerosis. You need to recognize which patients are at risk for inflammation. The very young, the very old, the uninsured. And just keep in mind that inflammation can affect everyone regardless of age, gender, race, or academic status, but that the very young, the very old, and the uninsured are at greater risk. Okay. I'm going to move through here. Just once again, acute inflammation is redness, swelling, heat, pain, and loss of function. Common diagnostic tests are almost identical to what you would do for immunity, a compromised immune system, CBC, a white count with a differential, a C-reactive protein, ESR, and any serologic test for specific antibodies or viruses. For example, you can have a rapid strep test. You can also check for the RSV virus rapidly. Radiographic studies to check for any tissue damage from the inflammation, like MRI, CAT scan, or PET scan, or colonoscopy. Provide appropriate nursing and collaborative interventions to eliminate this inflammation. So you want to medicate the patient appropriately as the physician orders with any anti-inflammatory medication. And there's COX-2 inhibitors that work a little more aggressively to do that. You might be administering something like steroids, in more severe cases, methotrexate, Humira, Plaquenil even. And then you may be giving an NSAID like Toradol for the inflammation, Motrin, Aleve, Mobix. Reducing the risk for injury and infection is key. You want to prevent this from occurring, maintain good hygiene, properly use safety equipment, and properly store and prepare food. So as always, you want to prevent this from occurring. The best intervention is prevention. No specific screenings are performed for the general population. You want to apply RICE or rest, ice, compression, and elevation to any sprain or strain or trauma. It'll help reduce swelling, and it's best used within the first 24 to 48 hours. Just keep in mind, again, that if you leave ice on too long, you can cause frostbite on the patient. And make sure when using compression that you're checking for skin turgor, capillary refill, edema, warmth and color in the extremity. You want to elevate the extremity above the level of the heart if at all possible. Okay. Here is just a recap of what I kind of already discussed. Antipyretics to treat the fever, like Tylenol or Motrin, analgesics to help the pain. And that could be anything from Tylenol to morphine, depending on the severity of the inflammation. Antimicrobials, anything from penicillin to a third-tier antibiotic. And in your interrelated concepts, inflammation is directly infected by infection and immunity, and it in turn affects everything from tissue integrity, thermal regulation, gas exchange, clotting even, fatigue and stress. Just going back to fever, I wanted to mention, hopefully I already did, but that you do at times want to allow your patient to have a low-grade fever because it does increase the flow of the white blood cells to that area that's been infected. It also increases cytokine release, and you just want to make sure your patient doesn't get too high of a fever because it can damage or break down the proteins in your patient's body if it's severe enough or high enough of a fever. And then don't forget, especially in children, when you have a fever, it increases the child's heart rate and respiratory rate to a significant degree for every degree in temperature. So you want to keep that under control, especially if your patient is having any kind of signs of increased work of breathing. Alright, that's the end of that presentation. It was a lot faster. And that was 22 minutes. Hopefully I didn't go too quickly through it. If you have any questions, please make sure to let me know.